Good evening, one and all. This is a IMA AMS Fellowship Course Launch program, which was a joint venture of IMA KSB AMS in association with the Ankur Hospital, Bangalore. We received a request from the Ankur Hospital regarding starting the new course in Andrology Fellowship. And personally, we did inspection of the hospital. In fact, it was very good setup. They are running already few courses. So finally, it is approved from the headquarters also, and this is the launch program. So I request our Manjunath Tekka sir, please read the IMA prayer, and we can start other agenda. I will just read for the prayer. May everybody be happy. May everybody be healthy. May everybody be free from the pain. May everybody be from sorrow. May be the healing cure beyond every greed and lure. Thank you. Long live IMA. Once again, I welcome our President Dr. Chinwala sir and officials from the Ankur Hospital and Master Health Pro, which is a joint venture of this program. I request our President sir to say a few words. Welcome.
Good evening to one and all. So first of all, I have to thank our Dr. S.Y. Mulki Patil for taking up this issue of AMS along with Ankur Hospital regarding this AMS fellowships. So most of our subcommittees under this one, AMA KSB, they are doing very good jobs and works for the betterment of the students as well as members. So I wish them all success, and with this joint venture with the Ankur Hospital, so let it take up and give good the benefit to the students as well as the members. I wish you all the best. Mulki Patil, can go ahead.
Thank you, sir. Welcome you, Dr. Sitaram sir and Dr. Five. In fact, the enthusiastic team we met during our inspection, Dr. Fahim and Madam. So I think you can start, sir.
So the topic that I was given to be discussing today is erectile dysfunction, the current management and future directions. So I'm Dr. Sitaram, consultant urologist andrologist from Hyderabad. We will only focus on the practical aspects. So theory, all of us will be knowing about the PDE5 inhibitors, implants, and the theoretical aspect of erectile dysfunction management. So today my intention is, after this 10-15 minutes of talk, people should be able to carry home a message that is useful in their day-to-day practice of sexual dysfunctions. So erectile dysfunction means not being able to get and keep an erection that is firm enough for sexual activity. This is erectile dysfunction. Many times people come to us saying that they are able to have sexual activity and everything, but they still feel they have erectile dysfunction. So without asking much, we assume that they are true. But most of the cases, the definition is they should not be able to have a firm enough penetration. That is the main point. So erectile dysfunction is estimated to affect over 50% of men aged 40 to 70 years and even up to 40% among men less than 40 years, which is a very significant number. And this is only statistics, and practically this number can be way higher than what we are seeing. So what is the current management that is available? The current management is PDE5 inhibitors, intracavernous injections, penile implant, low intensity shockwave therapies, and P-shot. I have raised a question mark near P-shot, and we will discuss why I have done so. And the future directions is regenerative medicine, low intensity shockwave therapies, P-shot, or stem cell therapies. This is the future direction that we are looking at erectile dysfunction management. So I have simply made a small chart that is helpful for everyone to understand about the PDE5 inhibitors. So sildenafil is a PDE5 inhibitor, the well-known famous blue pill. This is called the blue pill. And sildenafil has revolutionized the management of erectile dysfunction. It has tremendously improved the scope of managing ED. So sildenafil is available in 25 mg, 50 and 100 mg. So why is it so famous? Because of its potency. Sildenafil is a very potent drug and it is time tested, and the most important factor is early clearance. So sildenafil once taken has a T-half of just 2.6 to 3.7 hours. So it has a very quick clearance rate. So that is its importance. So that side effects are small time lasting, and especially in cardiac patients, if you want to restart their nitrates, sildenafil can be emptied out completely from the body within short span, so you can restart your nitrates again. But what is the side effect of sildenafil? Why are people afraid of the name of Viagra when they say, "Sir, will I get a heart attack if I take this tablet and all?" Why is that question rises? Because of its side effect profile. So we should not be prescribing sildenafil to people, elderly group, especially after 60, 65s, without any proper cardiac knowledge or clearance. The basic questions that you can ask a patient in an OPD is whether he is able to climb up 2 stairs quickly or not. If the patient complains that he has dyspnea with climbing of 2 stairs, then that patient is not a candidate to be started on sildenafil. Definitely he needs a cardiac evaluation, and then only you can prescribe sildenafil especially. So the cons are blue vision. Sometimes the patient complains when they take sildenafil, they get a blurred blue vision. And that is because of the cross reactivity with the PDE receptors in the retina. And then the second thing is cardiac problem. If patient has a known cardiac problem or a suspected cardiac problem, sildenafil should not be used. And the next thing is sildenafil should be taken only on empty stomach to have a good efficacy. And then coming to the next tablet, that is tadalafil. Tadalafil is available in 3 doses, 5, 10 and 20 mg. So the advantage of tadalafil is its daily usage. So you can prescribe tadalafil on a daily basis of 5 mg every day. What is the advantage of daily dosage? There are 2 advantages. One is the spontaneity, because if you give the medication every day, they don't need to think about when they want to have sex and take a tablet 1 to 2 hours prior to a sexual activity. So this gives more spontaneity and natural feel to the sexual act. And then the safety of tadalafil is much superior to sildenafil, especially in patients with cardiac issues. And then the next advantage is long T-half. Tadalafil has a T-half of 17.5 hours. So most famously it is used in the weekend time because of its long-lasting effect. But what is the disadvantage with tadalafil? It has a late onset. So it takes up to 2 hours to have a good efficacy. So if people are in a hurry, tadalafil is not the tablet to be taken for. And the newer drug in the market on shelves is Avenafil. It is available in 100 and 200 mg. So the advantage of Avenafil, the company and everyone claims, the literature claims that it has a very quick onset of action. In half an hour it will start acting, 1 hour it will start acting. But practically it is not so much effective in short time activity, but majorly it is having less side effects. So practice when we are using sildenafil, patient is having side effect, tadalafil patient is having side effect, and then we have given Avenafil, most of the patients did not have any side effect. So side effect is the main, no side effect profile is the main advantage with Avenafil. So how much to be given? You can start with 100 mg and then increase it up to 200 mg on demand. So that is Avenafil. So selecting the right drug is the most important aspect of choosing a PDE5. Giving a PDE5 is not much difficult. You can just write away sildenafil or write away tadalafil to the patient, but that's not it. The importance is choosing the right drug. So the parameters that we should look at is, one is age, second is comorbidities. If the patient is having cardiac problems, prefer tadalafil. If the patient has hypertension, prefer tadalafil. Lower urinary tract symptoms, prefer tadalafil because it can manage the lower urinary tract symptoms also. And if a patient is having migraine, the preference again shifts towards something of sildenafil because of its short acting time. Sildenafil is a preferable drug in patients of migraine. And then in patients with renal and hepatic issues, again tadalafil is a much preferable drug. But the only thing is, dose should be taken care of when the patients have renal and hepatic problems. So prefer to start with 5 mg. If not working, top up to 10 mg. And the second thing is dose reduction. If patient is having anti-epileptics, I prefer personally to use tadalafil, and I generally start with 2.5 mg tadalafil or 5 mg tadalafil daily, and if it is not effective, on demand 10 mg tadalafil. That's the maximum dose I prefer to go with anti-epileptic usage people, because there is a chance of triggering of epileptic attacks or cross-reacting with anti-epileptic medication. And when there is a hepatic or renal failure, again I prefer tadalafil. And when there is a patient of more than 65 years age, tadalafil is the go-to drug. So what is the frequency? So you should be knowing the frequency to prescribe the drug. See, if it is a young individual wants to have sexual activity just on occasional basis, once in a month, once in 2 months, sildenafil is the go-to drug. You can advise sildenafil to be taken at a 50 mg dosage or maximum 100 mg dosage, and that should do a good job. But if the frequency is high, every week the person has to meet 2 or 3 times in a week of sexual activity, sildenafil is not the right drug to choose from, and it would be a tadalafil to go with. And if there is a side effect profile, then avenafil. So, and the next one is premature ejaculation. When the patient also has premature ejaculation, I prefer to give sildenafil with combination of depoxitin because of their similar pharmacokinetics. But most of the times outside the available market is a combination of tadalafil and depoxitin. That's not a bad choice. Definitely you can consider tadalafil plus depoxitin as the second line management. And next, financial status. So if I just say tadalafil 5 mg daily, it may not be feasible. It may scare some patients because of the financial issues. They can't afford a drug to be taken every day. In those patients, again, going to sildenafil on demand is preferable, or tadalafil 10 mg, which is much cheaper than sildenafil, can also be taken. So what are the contraindications? The single most important contraindication that everybody should remember is nitrates. If somebody is on nitrates, PDE5 inhibitors is a big no-no. It should be consulted with the cardiologist before starting any PDE5 inhibitors. So my take, sildenafil, when will I be using the blue pill? I will use it in young patient and for one night usages, or occasional usages in elderly with no cardiac abnormalities. And then failed other drugs. If he has already taken tadalafil, he has already taken avenafil, then sildenafil will be tried. That has a high potency. And then patients with migraine, I prefer to go with a sildenafil. And what about tadalafil? Tadalafil is my workhorse and daily usage tablet. That is the main go-to tablet in my daily OPD. So it can be used on daily basis of 2.5 to 5 mg, or as a long-acting weekend pill. We can advise a 10 mg or a 20 mg single dosage on a Friday night, and the patient have the advantage for whole weekend. And tadalafil can also be used in penile rehabilitation, that is in patients with robotic prostatectomies where the recovery of the nervous tissue takes some medication usage of PDE5. So we give tadalafil 2.5 mg or 5 mg daily for up to 3 months in patients post-radical prostatectomies. And then in patients with renal failure or lower tract symptoms, tadalafil is the go-to choice. And avenafil currently I am only using in patients who had side effects with tadalafil and sildenafil. So because of the side effect profile, I am using avenafil, but the potency looks inferior to tadalafil and sildenafil, but I don't have any literature basis to compare that one. So coming to the side effects. So most commonly when we use PDE5 inhibitors, people come back to our OPD saying they got gastritis, they got headache, they got blurred vision, they got backache and lower limb pains. So what to do when the patient is having side effects? The first thing is to stop and start. Ask the patient to stop the tablet, whatever he's taking, wait for 3 to 5 days and restart the medications. Many a times, once you restart, the side effects tend to decrease after stop and start. Second is change of medication. If still you have a problem with medications, prefer changing the medication. Go from sildenafil to tadalafil, go from tadalafil to avenafil. So change the medication. And if there is severe side effects, if any of the medications, then comes the next picture, that is intracavernosal injections, regenerative therapies, or penile processes. So what can we do to avoid these problems is to start them on lower dose always and stop and start. This is very important. And then reducing effect. Many times patients come to us complaining the reducing effect of medications. Initially it showed very good improvements, sir, but now after 2 months, now that is not the same scenario. My effect is decreasing. I'm not able to have a good sexual activity. Then change the dosage or change the combination of medications, or the finally step up to another treatment modality like regenerative therapy. If it is not at all working, sometimes people take tadalafil 20 mg and we have seen many times patient take 200 with sildenafil combined with 10 mg tadalafil and everything I can find, and still there is no effect. So when it is not working, first we have to check is whether he is taking medication properly, that is whether he is maintaining the empty stomach for sildenafil, or he is maintaining the timing, adequate timing when he is taking tadalafil, how regularly he is using the medications as advised or not. And then lastly, check testosterone. If the testosterone is very low, the effect of PDE5s will be less. So testosterone at the right level can help optimize the effect of PDE5 inhibitors. So what to do when the pill fails? So when the pill fails, the best option available next is intracavernosal injections. So when we use intracavernosal injections, the response rate is 70% because it bypasses the whole hormonal and neurological influence. So what is available in the intracavernosal injection? One is Bimix, that is the stock solution of 4 ml papaverine. We can take 4 ml of papaverine, mix it with 0.1 ml of chlorpromazine, make it 4.1 ml, keep it as a stock solution in our OPD, and whenever needed, you can start taking from that stock solution and using to the patient. So what is the right dose to be using in Bimix? So that comes the tricky part. So what to do is, when you prepare the stock solution of 4.1 ml and the patient is in your OPD, take an insulin syringe, load it initially up to 0.1 to 0.3 ml and give it to the penis at in between 1 and 3 o'clock into the corpus cavernosum, and then wait for the response up to 10 to 15 minutes and see how the response is. If the patient is able to respond with that dose, then you can pre-fill the insulin syringe and then give the insulin syringe to the patient. So what is the maximum dose that generally can be used is up to 2 ml, but remember, once you are increasing the dosage, every dosage of 0.1 ml rise is going to raise the chance of priapism. Be very careful. If you are going beyond 1 ml, be very careful. If you are not confident in managing priapism, don't ever try the intracavernosal injection in the first place. But if you are trying, never go beyond that 1 ml point. And what is trimix? Trimix is you mix alprostadil, that is PGE1 inhibitors, to the stock solution of 2.5 or 5 micrograms is trimix. The disadvantage is you need refrigeration to maintain a trimix. So this is basically Bimix and trimix intracavernosal injection. So the main catastrophic complication with intracavernosal injection is priapism. The rate is up to 0.5 to 5.4%. So the most important thing to remember is you should have thorough knowledge about the Bimix, trimix and managing priapism. That is more important. If you have an knowledge on that, start intracavernosal injections. If not, don't prefer intracavernosal injections at all. And then every time when you give an injection, the first time when you give an injection, you should make sure that the erection is completely gone, and then only patient should walk out of your clinic. Without that, don't send him home. Once you know the right dose, then give the patient for home syringes. And other side effects that are there is bruising and fibrosis. So these are the potential side effects with intracavernosal injection. So explain it to patient, document the complications that can potentially happen, and then start intracavernosal injections. So the now favorite one that is among the people is the penile implant. Many places now intracavernosal injection is not being used at all. Many times when PDE5s fail, directly the urologists are advising penile implant because of the cumbersome and the complications and compliance that is associated with intracavernosal injections. So what are the penile implant? Penile implant is basically a silicone material that can be placed into the penis that can create an erection that is adequate for penetrative activity. So that is very good option for patients who are not at all responding to PDE5s or has a severe side effects with PDE5s. So what are the models that are currently available in market? One is malleable, the other one is 3-piece. The image that I have displayed is a 3-piece penile implant. So it has a reservoir where the fluid is stored, it has a pump, and then it has the implant main actual shaft. So these three things, cylinders, so these three things are important components of 3-piece implant. And then comes the malleable implant, where there is a silicone material and then which is placed into the penis. The difference between 3-piece and 2-piece is mainly that in 2-piece the material is fixed. So once you place it, the patient can only bend the penis. He can't make it small or enlarge at the time when he wants sexual activity. But when it comes to 3-piece, you have a pump and reservoir. So whenever you want, patient can press the pump, the penis will, the cylinders will inflate, penis will become engorged, and then it feels or resembles more of a natural erection to the patient. And when he doesn't want the erection, he can switch back the pump, and then the penis will become again small like flaccid penis. So this is the main important thing in 3-piece and 2-piece. So in 2-piece, which is a very famous one in India, most of the times, many centers, malleable is the most common one that is used. because insurance isn't covered in implants. 3-piece is very expensive, so 2-piece is commonly done, that is the malleable implants. So there are various companies in malleable implants. So we have Shah, we have Tactra, Zephyr, Resi, Tube or Genesis. So there are various companies that produce and sell these across India. So the thing is, we have to see which one is beneficial to us. Once you get hand of the implants, you know what is advantage and disadvantages of each implant, and you can choose accordingly which rightly fits to your patient profile. The key things that you look in implant is first cost factor, second is a material and the flexibility that it is offering, and then any antibiotic coating that is offered with the implants. So these basic things we can keep in mind, and then we can suggest to the patient according to his needs and requirements. So malleable implants are very safe, and it provides a permanent solution to the patient with refractive erectile dysfunction. So coming to the interesting topic, that is the low intensity shockwave therapy. So where does this fit actually? So in the treatment plan, we have discussed PDE5 followed by intracavernous injection followed by penile implant. So now where does the low intensity shockwave therapy fit in? So actually now low intensity shockwave therapy is emerging and people are using it at various levels. That is, they are using directly along with PDE5 inhibitors. They are using it when the PDE5 inhibitors response has decreased. They are using it when PDE5 inhibitors are working but patient is want a long-term remission, want cure. As a part of cure, low intensity shockwave therapy is being utilized. So basic concept in low intensity shockwave therapy is to restore the endothelial cell signaling and promote neoangiogenesis. So what is the basic mechanism of the low intensity shockwave therapy? It is the waves that it delivers. There are two types of waves that can be emitted from the shockwave therapies. One is the focus shockwave or the other one is the radial shockwave. The main key component when you are choosing a shockwave machine is to note which one it is. The focused shockwave therapy delivery, that is the linear shockwaves, are superior compared to the radial wave machines. So preference is towards focused shockwaves because it has convergent waves and it can deliver the focus very precisely. And combining it with Tralafil has a more synergistic effect of the outcomes. So there are various companies that are producing and marketing the shockwave machines. These are most common ones that we are utilizing for your reference. There is Stores, there is Medispike, Renovo, Dornier, Wolf, and Modus shockwave therapy machines. Each one has their advantage, disadvantage. There is no head-on comparison with all the machines, so we can't recommend any one over superior to other one on the outcomes. So you have to look into the company details. Mainly you have to look into the type of shockwave that it is going to deliver, whether it is a linear or a radial, and then the frequency range that it can offer, and then the focus size that it is going to offer. So we have to go into the details of the prospectus, see which one is the right one that we use for our patient profile, and then take the shockwave therapy machine. So another common question or doubt that people ask is how many shockwaves is the right shockwave amount? How many times a week we have to give? Currently, there is wide various heterogeneous literature that is available, and each company advocates their own one. But on an average, that at least what I am using in my daily routine is 5,000 shockwaves per session. Each session between 5 to 7 days is what I am using. It can be definitely argumented or debated, and different opinions can arise in this, which I respect. But this is what I am following and I am having good outcomes. The shockwave sessions on an average I am using is 6 sessions. So the next one is PRP and stem cell therapy. These are very fancy words that are being utilized, and many a times we use the word P-shot. Many patients come to OPD saying, I have taken P-shot, it is working, it is not working, or what is else more is there. So these are the two advancements that are coming up in shockwave therapy, in the management of AD. And if you remember, initially I put a question mark beside PRP or the P-shot because I don't think it is still emerged and can be used in a routine day-to-day practice. It is not still efficacious. So I think there is still time it can be used in future for management of erectile dysfunction. So what is the basic concept of PRP? PRP basic concept is to concentrate the vasculogenic growth factors, the epidermal growth factors, insulin-like growth factors and then inject that highly concentrated growth factors into the penis, which can help to regenerate the endothelium and the nervous system and help better erections. That is the basic concept of PRP. But there is wide differences in the concentration that is available in the blood of each person. So we don't know what is the right concentration that can be utilized. There are various studies that have suggested different modalities of using centrifugation methods, various concentrations of VEGF that are available at the end product. But we don't have a conclusive evidence, and most of these randomized trials have bias in their studies. So we can't derive any clear information from the trials. So because of the lack of homogeneity in protocols, we don't know number of injections that to be given. Is it 1 injection a week, total 3 injections, or 3 injections with a gap of just 3 days of time? We don't have any clear guidelines. And then the right concentration, how much ml you should draw from the patient, what is the end VEGF concentration that you are going to attain to get a good erection? We don't know anything about that. We don't know any qualitative or quantitative measurement of growth factors and how much interval to give between injections and long-term follow-ups. So currently at this point, PRP can be tried as a research modality only, but not as a therapeutic modality. And coming to the last slide, I will finish this with stem cell therapies. To simply conclude, there are 2 types of stem cell therapies that are mainly available. One is the adipocyte derived and the other is mesenchymal cell. We are listening more about stem cells because the FDA, mainly Western countries, have started it, and the FDA approval is not needed if you are using an adipocyte derived stem cell. So that's a big boon for them. They can bypass everything, every approval. They can take the fat derived stem cells and use it on the patient. But when you go to mesenchymal cell, that is from the bone marrow, you need permission from the FDA to do that. You need research permissions to start it. So that is the reason the literature on mesenchymal stem cell is limited, and more is on adipocyte derived stem cell. So here also the same issue, there is various heterogeneity among the protocols and the literature availability. So currently the stem cell therapy can only advocated as a research modality after clear explanation to the patient what type we are going to try. Is it adipocyte derived or is it mesenchymal cell derived? The advantages and disadvantages. And we don't have any long-term follow-up for mesenchymal cell. So if you take a stem cell from the bone marrow, place it into penis, what is the long-term sequelae? Will there be any chance of risk of malignancies or anything? We don't know. We don't have any knowledge on the long-term effects. So currently only we know is stem cells that are we using in different problems. We assume that similarly it can have an effect on ED and we are using it. So currently it is still research. So the other thing that is coming up is combination of regenerative therapies, that is combining platelet and low intensity shockwave therapy, taking the advantage from both the worlds and giving it to the patient. This is also still a research modality. You can explain the patient, combine the therapy. In my practice, I am doing 6 sessions of therapy and 3 PRP injections if any patient asks for a combined therapy. Otherwise, I am preferring only low intensity shockwave therapy for now. Thank you very much for the opportunity. I hope some information will be useful for you in your daily practice. Thank you.
Thank you, Dr. Sitaram. So, Dr. Sitaram has spoken on erectile dysfunction, the current trends and future perspective. So he basically with the current knowledge he had done a fellowship program at Ankur with Dr. Vasar, and he is a very knowledgeable urologist, which I know. And he has used his knowledge with real-time world troubleshooting from his andrology training. And the same, his talk exactly reflected what the fellowship aims to offer, and which is hands-on experience, the clinical knowledge, the everyday challenges where a doctor, a clinician is going to face in his day-to-day activities. So, thank you, Dr. Sitaram, for contributing to this symposium launch. Basically.
Thank you, sir. It's my privilege.
First of all, apologies. I was late because of Mumbai floods, but a warm welcome to each and every one of you. And today marks the historic milestone, especially for the grand launch of this first ever official fellowship in andrology and sexual medicine. And this pioneering initiative is proudly, I should say, powered by the Indian Medical Association, the Academy of Medical Sciences, Master Health Pro, a premium brand in healthcare excellence, especially in the realm of andrology and female reproductive science, and the iconic Ankur, which is led by none other by the Chiranjeevi of andrology, which I always say, Dr. Vasan. So this is just not a launch, but it is basically a new era in specialized training, academic excellence, and patient-centric innovation in the field of andrology, which consists of male sexual dysfunction and infertility. First and foremost, I like to extend my deepest gratitude to each one of you being a part of this landmark occasion, and it's my immense joy and warmth that I welcome wholeheartedly Dr. Chiniwala, the President of Indian Medical Association, Karnataka State Branch, Dr. Suri Raju, who is an Honorary State Secretary of IMA Karnataka Branch. Also, I have met Dr. Mulki Patil, the Chairman, and Dr. Manjunath, the Secretary of the IMA AMS Karnataka Branch during our inspection. So all of your gracious presence today not only honors us, but also elevates the spirit and significance and the importance the IMA has given to this subspecialty of urology, specifically the andrology, which was always at a back seat in Indian scenario. This course, let me say proudly that it is not just any other program. It is very comprehensive and first of its kind fellowship designed for registered Indian medical practitioners only. And the best part is it is certified by IMA AMS as well as accredited by the Rajiv Gandhi Institute of Health Sciences. So it's a moment of pride in the field of andrology as well. So, namaskara and a very good evening. I have not introduced myself. I'm Dr. Fahim. I'm a consultant urologist and andrologist. I work with Dr. Vasan and I'm in Bangalore. I'll be helping you through the program launch of the event as well as how Dr. Sita has shown his skills after learning andrology and applying troubleshooting skills in his presentation. I will be giving a different outlook towards my presentation. So now this course doesn't only give theoretical knowledge, but also give practical experience as well as hands-on observational training as well. And this course is not led by only single person. It is led by one of the finest minds in the field of andrology, not only from India, but across the globe as well, which makes this really special. And help us to understand a multi-modular, multi-country, multi-mind approach so that we'll be able to treat our patients in a very comprehensive and integrated way. So the key points of this course I want to mention is this: for the course, to enroll for the course, you should be a IMA Life member and IMA AMS Life member. You should be a postgraduate in their respective fields. It can be urology, general surgery, obs, gynec, endocrinology. The duration will be for 1 year. There will be one batch, and the number of intake which we are taking as of now, as per the inspection which we have cleared, is 10 students in a year. Minimum, we are very much strict on our attendance, because if a person is not contributing his mind, body, soul and energy into the field, the outcomes will not be great. So we'll be very strict on the minimum attendance of 80%. There is no supplementary exam in case the student does not appear during the examination dates, and he has to appear as a fresh candidate in the next year. Also, the theory part will be taken care by at the center of Indian IMA as AMS, and the practical examination will be taken care by Ankur Healthcare at Rajajinagar, Bangalore, and the results will be out within a week. And certificates definitely will be supported by IMA AMS. So, with this, I welcome you all to this wonderful launch of Fellowship in Andrology and Sexual Medicine. And for the course details, I would like you guys to take the screenshot or number, so that we'll be contacting Josephine. So he will be helping you in terms of logistics who can join, how can they can join, what are the minimum requirements, what are the fee structure, what are the things which are required to get into the course. Okay. Now, with
Dr.
this,
Fahim, just one clarification from somewhere.
yes, please.
This regarding it is basically IMA AMS headquarter course, but definitely RGHS, just clarify with that, because before putting the names, so unless you have this thing from the intimation from RGHS, I think
Okay.
yeah, just need a clarification.
Definitely. I'll just get back with the MH
Yeah.
Pro team as well.
Okay.
And then I will get back and we'll be correcting and we'll be sending those flyers accordingly then.
Yeah, thank you.
Sure. Thank you. So with this, my second topic of today is interpretation of basic semen analysis. So as I told, Dr. Sitaram has taken his basic knowledge in science and skills and everything and started with the treatment options. Who will work for what? I will be giving a different scenario, how I will start from a beginning to come to a conclusion to what to do next. So this is what is all the fellowship is all about. That we will be taking care from both the ends so that we will be giving a comprehensive treatment to a patient. So yes, I have introduced myself already. So what is the need of semen analysis? As we know, the God doesn't want to give an abnormal baby to anyone. Let's say that. That's the rule of law. So best sperm and the best oocyte will give best quality embryo, and that will give a successful pregnancy and successful live birth. But with the current rampant use of IVF ICSI in the current scenario by many doctors in the field of infertility, also we are facing complications related to IVF or ICSI in terms of, let's say, poor embryo quality, abortion risk becomes high, the failures of pregnancy to continue, the genetic abnormalities in the babies, and long-term implications of IVF in vitro fertilization or ICSI babies has still not been completely into compact data to explain the patient regarding what statistics, what are the chances of getting a normal baby, what are the chances of continuing a pregnancy, what are the chances of getting a good quality embryo. So this semen analysis is just kind of a touchdown approach towards a field to understand the concept. So with this presentation, we'll be able to have three things. Number one, how to diagnose a sperm dysfunction. Number two is sperm optimization for a natural pregnancy and selection of quality sperm for any kind of assisted reproductive techniques. So before that, we need to know few things before opening the envelope of a semen analysis, that the patient should have a constant duration of abstinence in terms of masturbation or a sexual activity. The entire ejaculate has to be collected in the container, with it preferably at a laboratory, and should be immediately submitted to the lab and transported if possible at 20 to 27 degrees. So before interpreting any semen analysis, I will ask some WH questions towards me myself. Which laboratory, what edition, what clinical history, and what physical examination, and how many samples, because the seminal parameters, they do vary, and the European Association also says that we need to do repeat use analysis just to have a complete picture. So again, I'll be running. So these are the slides I've covered. But yes, okay. So yes, after reading the report of semen analysis, we need to answer just WH questions. Let's simplify our life in terms of what investigations are required, what is the diagnosis, what treatment, how to prognosticate, and when to refer. So the next thing is we need to have a standardized procedure as which lab which we are going to do. They should be having a standardized procedure in terms of collection, examination, processing, good quality control, which has to be comparable with the other centers. The trainers, the lab, andro lab technicians should be well trained, should be competent, should be reassessed, and the equipment and the facilities should be according to the current standards. Semen analysis. So if I divide the seminal fluid into two components, basically the semen plasma and the sperm itself, we have to detect where exactly is the problem, and then overall we have to see how the quality of the sperm changes. As I told you, the best sperm, best egg gives the best pregnancies. So if I want to have a semen plasma analysis, we need to see 1, 2, 3, 4, 5, 6 parameters: the volume, the pH, the color, the pus cells, the viscosity, and the agglutination. So regarding the volume less than 1.4 ml is considered to be pathological according to the recent criteria. It can be because of spillage, low abstinence period, aging, lifestyle and environmental factors, the infections, and the endocrine and hormonal changes. So if we know the cause, we have to take a particular history and we can direct ourselves towards the treatment. Okay, it can be because of obstruction, functional or neurological, in case of retrograde ejaculation or autonomic nerve dysfunction, or it can be iatrogenic based on, because most of the patients we miss out, patient might be taking some kind of antidepressants or a serotonin reuptake inhibitor or other medications which might affect the ejaculations as well. The next comes the color of the semen. So color is, it can be red, which is called as hematospermia. It can be yellow because of jaundice or white multivitamins or dehydration, or it can be brown in terms of spinal cord injury. The third is the pus cells, which is most commonly seen, and it has to be treated because it will give amazing results in terms of sperm quality. So round cells which are present in the semen analysis can be an immature germ cells or a leukocyte. So we do something as orthotolidine peroxidase test or HENS test, which are leukocyte positive. And based on that, we can do a semen culture or a PCR, and based on the physical examination, we will be knowing where exactly is the infection hitting. Either it can be in urethra, prostate, or epididymis, and we can give an antibiotic course accordingly based on what kind of organ is involved. See, genitourinary system should never be isolated in terms of overall kidney, ureter, bladder, prostate. That's it. No. Every organ is different. The urethra is different, the epididymis is different, the testes is different, the prostate is different. Every organ has to be taken care into consideration and respected and treated accordingly. That's the target, because each hormone has its own function. So this slide is one of my favorite slides, which I always say. The WBCs, or the leukocyte in the sperm, it produce reactive oxygen species, and they destroy the mitochondrial DNA and affect the sperm motility as well as the function itself. And it will cause subfertility in a female, because females, for no reason, they might get a urinary tract infection and with a high risk. Okay, so currently there are no guidelines which antibiotics we should do, but yes, definitely as per whatever the local antibiotic protocol is, we have to treat the patients accordingly. Of which two are more important: chlamydia and neuroplasma are to be statistically involved in lowering the sperm vitality and concentration respectively. The next comes is the pH. pH is not to be taken only isolatedly. We have to see in terms, correlate with the fructose level, the volume of the sperm, and the sperm presence or not. And we have to come to a conclusion in terms of, let's say, seminal vesicle dysfunction or agenesis, because seminal vesicle contributes to at least 80% of the semen volume, or may indicate a prostatic hypersecretion in case of acidic pH. Also, in case of azoospermia, low volume, fructose low absent, it can be a congenital bilateral absence of vast difference. It can be confirmed priorly on a physical examination. So the importance of physical examination is must in the field of andrology. As well as if we do a truss, if we see a seminal vesicle more anterior posterior diameter more than 1.5 centimeter, it can be an ejaculatory drug obstruction as well. The next thing is the liquefaction time, one of the most common abnormality which is seen, and the reproductive medicine specialist complains that the males are infertile. Yes, definitely it is associated with some impact in fertility, but does not indicate infertility. So it is because of the imbalance between prostatic and seminal vesicle secretions, and more than 30 minutes is considered to be abnormal. When it is abnormal, you should always go for more tests to detect why it has happened and try to optimize sperm and direct towards the infection and inflammation of accessory glands, anti-sperm antibodies. We can do a DNA fragmentation or an ROS, a reactive oxygen species analysis. Try to optimize that. Automatically your liquefaction times may get optimized. The next is agglutination. Agglutination is kind of overrated in a semen analysis report, which is seen in 10% of infertile men and 2% of fertile men. If there are some non-specific agglutinations which are not clinically significant, but yes, which are adherent to the sperms. They are basically sperm antibodies, and definitely we have to. It guides us towards DNA fragmentation or an reactive oxygen species. So these are the different degrees of agglutinations. Now comes the most important thing, microscopic semen analysis. In microscopic semen analysis, again, we have to see 5 things. The number is concentration, motility, vitality, morphology, and intracytoplasmic droplets. I'm telling based on this WHO 6th edition. So 5 plus 6, 11 parameters, and it will help you to know where exactly the patient lies, which I always say to my patient, Dr. Sitaram also will be doing. I put my patient either in India border or Pakistan. If he is in Pakistan, near the border of India or way inside Karachi. So that is what the sperm analysis is all about. So this is a very important slide which shows that a person who is of 50th percentile, I'll go on the next slide, which will be more easy. A person with a 50th percentile is a strong fertility potential, normal male factor, no male factor basically. And we have to go towards a female factor. The person with less than 5th percentile in terms of motility, concentration, and normal cells is a person who requires definitively hormonal genetic evaluation and imaging. High likely this patient will go towards any kind of form of ART, basically ICSI. It can be big C, it can be IMSI, it can be with a surgical sperm retrieval to get a baby. But optimization is must prior. Person who is falling between 5th to 50th percentile is a subfertile guy. He is basically in the borderline. If we are able to correct all the correctable factors, we can shift him towards more than 50th percentile towards the natural pregnancy, which is what is all about the current WHO 6 guidelines. And there are some patients which might stabilize within that 5th to 50th percentile. We can give a chance of natural pregnancy. If it is not happening, then maybe we can go for an assisted reproductive technique in terms of IUI or IVF or ICSI. The concentration, very important, one of the factors, overrated I should say, it's the number of sperms per ml, and there might be a natural fluctuations, and there will be a number of reasons. It can be because of natural fluctuation, hormonal imbalance, genetic abnormality, infections, varicocele, and lifestyle. The current report says that we have to evaluate even if it is less than 2 million, and it alone, if there are low sperm concentration, doesn't say that the person is fertile or infertile. We have to always check with the volume of this semen. So these are the parameters which says that 50 percentile, 50 to 5th to 50th, and less than 5th. So this will help us to know where exactly the patient falls. So the red ones should be marked in our report that this is one which falls towards pathological. This is a borderline where I might be able to improve to an extent. The same thing, for example, if concentration is less than 10 million, go for an hormonal profile. If it is less than 5 million, I always freeze a sample. It means that patient is approaching towards 0. I will freeze a sample, try to optimize, and then take a decision. Because for making curd and rice, I need curd and rice, right? And if I don't have curd or rice in adequate proportion, I cannot make the dish. So I need it. So I will freeze some sample of this seminal fluid with the sperm and will optimize. The next is motility. So the motility, according to the WHO 6th criteria, has been divided into progressive and non-progressive. The progressive have been further divided into rapid and slow progressive. And it has been said that rapid progressive helps in achieving natural pregnancies, but these are all old data. The new data has not suggested anything, and these are the 3 parameters which helps to understand where exactly the patient stands in terms of fertility. The third part is vitality. When it is, let's say, around more than 54% is considered to be normal. Now, why sperm vitality is important? Let's say you have a semen analysis report and you see that sperms are present but they are non-motile. A non-motile sperm can be a live sperm, but non-motility, or a dead sperm which is dead because of death, it is not immotile. So vitality helps us to differentiate these two. Even if the sperms are immotile but alive, these sperms can definitely be used for an ART-ICSI, and then we will be able to give them a chance to have their own offspring in terms of genetics. Now, if the motility is low and vitality is normal, it means there is some structural or metabolic defects. But if both are low, there might be a testicular and epididymal dysfunction. So I always consider testes as a different organ and epididymis as different organ, and I target the organ accordingly because both has different function. There are various tests which are used to differentiate a live versus a dead immotile sperm. It can be eosine or nigrosin. The HOS tests are used in the IVF lab, and there are fluorescence staining methods as well. The next comes the morphology, the super overrated factor in semen analysis, which assess the size, shape, and structure based on Kruger criteria and reported as percentage of sperms. So it can be done by a staining method of perpendicular or short staining. And it is associated with reduced fertility, poor embryo quality, abortion risk, and pregnancy rates, and associated with high DNA fragmentation and ROS. But it should never be standalone. It should not be taken into consideration. It should always be interpreted with motility and other functional tests for decision making. If it is less than 4% but counts and motility are normal, may not always mean that he is infertile. Optimize and try for a natural pregnancy. If everything is low, yes, there is a severe production defect, maturation defect, go ahead with an ICSI. So these factors, if we are able to stratify it correctly in a stepwise manner, we will be able to understand where the patient stands and how we are optimizing. And that is what is all this course is all about too. So all of these things I don't know, I was able to tell before, let's say 10 years back when I was training in urology. But after doing andrology fellowships and understanding the true sense, all the statistics, percentage, the troubleshooting, the risk stratification, and the treatment plan comes. So that is what is this training is all about. So if the normal forms are 1 to 4%, suboptimal, as I said, we can go for an ART. But if there are less than 1%, fertilization risks are very poor. Go for a freezing of sperm and use advanced technique. Now, morphological indices, most of the centers, they don't do. Only, let's say, it helps to know that if we want to use any advanced technique in terms of PIXI, IMSI, or magnetic MAX, basically, just to make sure that we give a very good quality sperm in terms of our embryo quality, our grade outcome, to reduce the abortion risk, have a live good pregnancy rates. The only important factor is 1.72. If it is 1.72, don't. That's the only thing you have to remember, and go ahead for a advanced sperm selection technique. Last, cytoplasmic droplets. It is linked with associated with immature spermatozoa and incomplete spermatogenesis. It has been told by WHO6 that we should look for it. Long-term data is still not seen, but yes, this is the new thing which has come into the reporting system, just to make sure to detect any testicular dysfunction, epidermal transit defects, oxidative stress, or if there is a varicose, treat it. The next thing is, you might be hearing patient is having oats, mild oats, severe oats, very bad oats, mild. All those things are just cut off now. Now it has become more systematic. There is no normozoospermia, there is no asthenozoospermia, there is no teratozoospermia. The only zoo is for animals, and the only zoo which is important for us is azoospermia. That's it, where there is no spots. So the reference range has been transformed from WHO to correct distinct limits, where we classify the patients into subfertile, fertile, and semen analysis alone is not a prognostic of fertility. Fertility of a husband and a wife together will be able to tell that how the couple is fertile or subfertile in as a whole. And yes, definitely, semen analysis is a better prognostic value by using combination of factors. We can't just take one factor and tell the male that you are infertile or subfertile. So that's what this slide is all about, where mild, moderate, and severe oats has been considered. The mild oat is gone into borderline as well as pathological, and the moderate and the severe oat has gone into pathological categorization of WHO 6. So this is what I was talking about. The borderline decision limits has been now, the mild oats has been converted into the moderate, the oats into the borderline decision limits. So fixed reference values which were have been obliterated now. It is the old value, the old WHO 5th had a limited clinical flexibility, so it overestimated or underestimated fertility potential and did not allow patients to have a chance to have a natural pregnancy. But WHO 6 has become more flexible, more strategic, more stratified, and we give a chance or a patient to optimize themselves and go for a natural pregnancy. So this is what this 2 slides is all about. And with conclusion, our aim is to downgrade our treatment from IVF to IUI to natural pregnancy, and so that and upgrade our treatment from natural pregnancy to IUI to IVF in a stepwise fashion. And this is one of my favorite slides, because we have to take a clinical history, physical examination, treat the plasma abnormalities, sperm abnormalities, correlate with a hormonal profile and the imaging, stratify into a normal, borderline and pathological WHO 6 criteria, optimize the sperm, consider the male factor, and then decide natural pregnancy, IUI, IVF, ICSI, testicular sperm, advanced sperm selection technique. So by this, I want to conclude my sperm analysis. This is the other part of the whole presentation I wanted to highlight is, I have gone from the basic science to understand what the patient problems are. And the same thing Dr. Sitaram has done. He has taken a basic science knowledge and now he is implementing and stratifying and troubleshooting what patient, what treatment, what management, and how we'll be able to optimize a man as whole in terms of sexual dysfunction or male infertility. So this is what is all about of this course.
Thank you so much.
Yeah. Yes. So heartfelt congratulations and thank you to all the IMA team to helping us so that we'll be able to spread knowledge about the field of andrology among colleagues so that patients will not be treated suboptimally.
Thank you, Dr. Fahim and Dr. Sitaram, for giving the overview of the course as well as the the various approaches, starting from the, as you said, basic to the advanced, medical and surgical. Really, it was very interesting. I think parallelly there was questions, sessions and answers were going on. If there are any other questions, we can raise. Otherwise, from our side to the participants, yes, definitely, shortly, as the course is launched today and admissions are open now, it's a totally, the new fellowship in this part, and this is the second fellowship from the IMA AMS side also in Karnataka. Definitely, we are looking forward to have the better outcome from this course also, ultimately to help the needy one in the public, as this infertility rates are increasing, particularly in the urban cities. I hope this course will help in future. Thank you so much once again for both the speakers and also the Master Pro Health, Jashwin also. I think the phone number is displayed. For anything, you can reach us either to IMA AMS or directly to the Ankur Hospital. Anything, sir? President, sir?
Thank you, Dr. Maliki Patil, and all the speakers on both regarding the erectile dysfunction and also sperms. This one, it's a very good one. So such courses can be continued in this one. Dr. Sitaram, thank you for your very good topic.
Thank you, sir.
It's the erectile dysfunction. Thank you, one and all.
Thank you.
Thank you, sir.
So
Thank
with
you all.
this, I would like to conclude this launch of our fellowship program and hope to see the team on regular basis, so we'll be able to upgrade our knowledge as well as spread the knowledge. Very happy that IMA has taken a very amazing initiative so that we'll be able to spread knowledge in a very systematic way.
Thank you.
Thank you.
Thank you, Dr. Naeem.
Thank you, Josephine, for being coordinating everything.
Thank you, Josephine, doing all the work behind the screen.
All the backhand work, yes,
Yeah, yeah.
definitely.
Yeah.
So we'll be keeping torturing you, Josephine, so that our work becomes more efficient.
Yeah.
Yes, surely, Doctor. No issues. And thank you to all the participants as well for joining this webinar, this special course. So I look forward to your participation in the course enrollments. Thank you. Please do reach out. I have put my number in the chat. You can reach out for any course details and even the pricing details and application form details. You can reach out to my number. Thank you.
Thank you, sir. Professor,
you,
thank
thank
you.
you.
For time.
Yes.
Thank you.
Thank you. Thank you.
Thank you so much. Thank you all the participants responding
Thank
in
you all
the very good listing participant. Almost nearly 50 people were attended. Thank you once again.
Thank you. Have a nice evening.
Yeah. Thank you.